Welcome to the Wild Physio Podcast and the Be Strong Physio Podcast with your hosts, Andrew Wild and Geoff Ford. Today, we have Dr. Tom Cross back. How are you, Tom?
Very well. Great to meet with you again. Great to have Geoff with us.
Yep, indeed. We got both Geoff, myself, and Tom. We were going to do this last year in Sydney, but unfortunately, it was around the time when Merv, your father, who was the founder of this protocol, passed away. So this podcast is somewhat in honor of Merv. So sorry to hear about your loss, but he was a true pioneer, wasn't he?
He was, and yeah, thanks so much for mentioning Merv. He pioneered a lot of things, surgical in orthopedics, and then in the last phase of his career, and he was actually retired when he did this incredible discovery of the bending the knee and immobilizing it to facilitate the healing of the ACL. Quite a paradigm shift for a knee surgeon to pioneer a non-surgical treatment. So it's typical of Merv that he was so strong and pioneering and thinking mainly of the patient always.
Yeah, he was a great man, and I'll never forget that podcast that we did in person with Merv. I think it was about 2 or 3 years ago now, and
Yeah,
it was
fantastic.
a it was an unbelievable day. I loved it, and it was an honor to meet him in person.
Thanks again.
Now, let's dive into what the cross bracing protocol is and just some of the key points around it, because some people have probably heard of it, but some that are listening to the podcast or watching on YouTube haven't heard what the cross bracing protocol is.
It's a novel approach to um, managing an acutely ruptured ACL, a knee injury. It's for the last 5 decades, thank God we've had uh, expert knee surgeons who can perform ACL reconstructive surgery. Because prior to that, a lot of people suffered ongoing instability and dysfunction and impairment because they were ACL deficient prior to 1980, 1975. So for the last 5 decades, we've had you can do rehabilitation alone, or you can do ACL reconstructive surgery. And this is another non-surgical treatment where the patient puts a brace on in order to facilitate, we believe, the healing of the ACL. So it's quite a challenging medical paradigm that the ACL can heal, because for many years I was taught, and many doctors and physical therapists and allied health patient professionals were taught the ACL cannot heal based on anatomy, physiology, etc. But that myth has been dispelled, particularly in the last 10 years, with many papers written on spontaneous healing, many in vitro studies on ligamentous healing in humans and rats, etc. And now we believe our paper published last year in June in the British Journal also adds weight to the fact that the ACL can heal, that certain ACLs can.
And with this research that you have undertaken, where are we at in terms of how many patients have gone through the cross bracing protocol now? Because back when we chatted last year, it was 369 people. I think that was the 22nd of June last year, had gone through the cross bracing protocol. Where are we at with it?
And we're now up to 585. So patient 585 braced 2 hours ago here at the Stadium Clinic. He was a skier. He was injured over in Deer Valley, Utah. It's interesting because I saw patient 293 in the clinic this morning, who's a skier from Canberra who ruptured her ACL skiing in Japan this time last year. And in the space of 12 months, we've gone from patient 293 to patient 585. So it's like a doubling in the last 12 months. As I think that's attributable to just a slow spreading of knowledge from clinicians who have taken patients through the treatment, of patients talking who have been successful, the publication. So it's certainly getting some more gravitas behind it, and confidence, particularly for the patient, that this is another approach. You can always have surgery. God forbid if it doesn't work. You haven't burnt any bridges. It's an approach that some patients may want to take. That's a non-surgical approach to hopefully get a better healing outcome.
Yeah, and if someone does rupture their ACL, we were talking about it before we started the podcast about it being time sensitive. If you could just dive into why it's time sensitive and what we should do in those initial phases in the first week to even shorter than that, 5 days. And we touched on it a little bit last year about what should be done
Mm.
if one does rupture their ACL while overseas skiing. And we talked about the anticoagulants and when to start to use those and when to brace and then when to fly home. So just touch on a few of those very important points.
Yes, I'll answer that in two parts. We've learned a lot in the last five years since we've been bracing people in earnest. So the first 5 years was 2014 to 2019, and 5 people did the protocol who were family, friends, colleagues who trusted Merv and I that on a completely new paradigm shift of putting a brace on to heal the ACL, not only putting a brace on, but going to 90 and immobilizing. And then over the last 5 years, we've learned a lot about which patients do well and which patients don't do so well. And one of the key determinants is, like any orthopedic injury, is number one, getting an adequate reduction of the injured tissues so that they're opposed, and number two, doing it early before that tissue. We use the term involutes for want of a better word, the ACL tissue that's ruptured. If it's not engaged with its fellow on the other side within the knee, it basically gives up and caps over and involutes, and we call it a dead ACL. Analogous to a fracture that's not reduced and becomes a non-union, or skin that's, you have a big gap and a gaping wound on your skin. You wouldn't leave that unreduced and unsutured. You'd bring the skin edges together so they're opposed. So there's a critical time to get the ACL reduced by bending the knee. And from our research, it varies between individuals, this phenomenon of the ACL giving up and dying. And it can start happening as early as day 8. And then for everyone, we think everyone's ACL is involuted by day 21 from our research of meticulously looking at MRIs, seeing how they heal or don't heal. So with that in mind, we think the ACL, and this is quite a paradigm shift, is basically similar to a fracture. So the 14-year-old girl that comes into the emergency department this afternoon with a broken wrist, she may have an undisplaced fracture of her wrist, and it's just a crack, and it just needs an awareness by the doctor and the physio in the emergency department that she needs a splint on. It might be a soft splint. And then the next girl will have a displaced fracture that just needs a closed reduction. She has a sedation and her wrist put into position with a plaster on it. So that's a non-surgical closed reduction of her fracture. And then another girl may have a profoundly injured fracture. It's displaced, intra-articular. It needs a surgeon to do an open reduction and fixation with plate and screws. So just like the fracture is time sensitive and you wouldn't leave it for weeks in the outpatient area, we believe the ACL deserves equal attention to classify the injury into a non-surgical arm or a surgical arm. So that's quite a paradigm shift for all of us. And it's particularly pertinent to children, because the children are the ones we need to really focus on, because they carry the burden of an ACL injury for much longer than a 45-year-old who does their ACL. So we really need to jump on the children and get them diagnosed early, and if they're appropriate for non-surgical treatment, put them into the brace early before the ACL gives up. Then the next part of the question was anticoagulation for the traveler. And it's interesting, in the beginning of this work, Merv and I reached out to several vascular surgeons, vascular physicians, and hematologists to get their expert advice on, we don't want to do any harm to patients, like causing them a DVT by taking an acute knee injury into 90 degrees and locking the knee at 90, which is quite aggressive. And that's why some clinicians are fearful of the treatment. And I don't blame their concern, but I can reassure them that we got expert advice, and the advice was to do a Doppler on everyone before we put them in the brace. So we do a thorough Doppler ultrasound to make sure there's no DVT, and then we anticoagulate all the adults. So anyone that looks like a physiological adult gets an anticoagulant while they're non-weight bearing. And with that treatment, we haven't had any DVTs or pulmonary emboli. And obviously death is the worst outcome. No one's had that. But we've had 4 DVTs in people who forgot to take their tablets. They were usually at university, at college, and they just forgot, and they just suffered a below knee DVT, and we took the brace off and increased their anticoagulant to a therapeutic dose. But what we did notice was anyone who drove into Sydney from the snowy mountains from a ski injury, like a long drive, or flew into Sydney or Melbourne or New Zealand from overseas, it was the traveling skier or the traveling ACL that got the DVT with the Doppler. So with that in mind, anyone who's listening, who's a patient or a clinician managing a patient who's had an ACL and then got in a car and driven for a long period of time or flown internationally, you're at much elevated risk of a DVT. And with that in mind, the medical teams looking after these people in the ski resorts, I believe, do need to really focus on getting these patients safely home to where they live, and going through not only looking after their knee injury, but also managing the DVT risk. And they're not doing it, unfortunately, at the moment. It might be a litigation problem that they're scared of putting a patient on an anticoagulant with the risks of that. If they bleed, if they fall over and get bruising, cut their skin. But yeah, this is another topic. But anyone who gets injured skiing overseas really has to talk to the doctors and physios about how do I mitigate the risk of getting home safely without a DVT, God forbid a pulmonary embolus. So that should be really talked about more.
And Tom, has the classification system to determine if a patient who's ruptured an ACL is a good candidate for the cross bracing protocol, has that been finalised or changed since you last chatted to Andrew?
Great question. That classification system has evolved over the last 5 years. The brave pioneering patients who were the subject of the publication last year, they're the first 80. They navigated the protocol just being told on first principles, we believe this will facilitate your ACL healing. And it took us to patient 38 before we started seeing a pattern of who did really well and who did poorly and who we were in the middle. And we started to look at certain criteria on the MRI, as well as the time to brace, which is the interval from injury to going to 90. And it's taken thousands of hours of meticulously looking at what the acute MRI looked like and then what the 12-week MRI looked like. So we call that the acute classification and then the healing outcome classification. And that's continued to evolve, and we get more and more evidence of the criteria we're looking for are predictive. We've written the paper between the authors of that. We're calling that paper 2, and it's in its final stages before we submit it. So yeah, the things I can talk about it, the criteria we look for, it's just like a fracture. So it obeys the anatomical principles of how badly hurt is this body part, and the orthopedic principles of reduction, and do you achieve an adequate reduction by bending the knee to 90 or not? And what determines that on the MRI is how separated the ACL tissues are in the notch. So we've come up with a nomenclature or a taxonomy of wording what we're seeing. And so one of them is called gap distance. So we've come up with that term to describe the gap, which is the average separation of the tissue. And that can vary from 1 millimeter to 15 millimeters. So gap distance, just like a fracture, how displaced is the fracture or separated in space. The next term is displacement, where the femur's rotating so forcefully on the tibia at the moment of ACL injury, it throws ACL tissue out of the notch, usually anterior and lateral. So you'll see a big piece of ACL tissue sitting under the lateral femoral condyle. So it's completely out of the notch or the anatomical site of the ACL. And that's not a good sign because you bend the knee, some of them actually unflip and reduce back into the notch. We don't know why. We think because the knee is like an aquarium and the ruptured ACL is like seaweed floating around, and it might just float back in. But the patients say, well, will mine float back in? And we say, we don't know. Some of them do, some don't. Do you want to take that risk? And if it doesn't float back in, they'll get an hourglass or reduced thickness heel in what's called the healing zone, where the tissue in the notch that's capable of coming together heals. And they just have to accept that they're going to get an hourglass heel potentially.
Just quickly on that, Tom, where are we at with potentially being able to unflip that bundle?
Yeah,
So we can, like in
ask.
surgery or something like that, are we any closer to potentially facilitating that?
The answer is no. But so many patients ask me that when I talk to them about this displacement of tissue out of the notch, and that they're unfortunately in that category of they've had a lot of force go through their knee when the ACL ruptured. And what comes with that usually is a larger gap distance in the notch of the tissue and displacement. It may also be associated with a partial femoral avulsion, and the tissue that's displaced down the bottom under the lateral femoral condyle or out the front has come from the femoral footprint and been thrown out. There are surgeons who do ACL repair surgery in Australia and internationally, but their criteria is looking for the proximal ACL injury right up the top, so that they can grab that ACL tissue and pull it into a tunnel. But no one's performing what you're talking about, is recognizing, well, that's the pattern of injury. It's like a fracture. I'm going to go in there acutely while the ACL is still alive and unflip that displaced tissue and put it back in position in the notch. That's not happening. It'd be it's an intriguing and pioneering orthopedic challenge. I think if Merv was still alive and still operating, he'd be doing it next week, knowing him. So, but we'll see. We'll watch this space.
Well, moving on to the outcomes of the protocol at this stage, what percentage of people are you finding have signs of healing at that 12-week MRI?
Well, that's a great question. It all depends on where you are on the spectrum of injury. Okay, so think of it like we've touched on it today. The ACL is injured in a spectrum from minimally hurt, like a partial tear, to a profoundly injured ACL, where it's large gap distance, large percentage displaced, large percentage taken out of the femoral footprint. And it really depends on where you are on that spectrum as to what your healing outcome will be. Either if you choose rehab alone or the cross bracing protocol. So in our hands, that we've braced 585, and you've got to remember this is being done in private practice where every patient is treated as a patient. We're not randomizing. It's a case series in private practice. And we're treating patients differently now than we did 3 years ago because we have more knowledge, and we don't want to. So we're having a very meaningful conversation with them about their ACL injury, about them, about what are their demands and what are their goals and what can they execute this treatment? Do they have enough support? Is it their right knee, et cetera, et cetera? But right knee means, can they drive? So in our hands, we're getting 95% healing, but that healing is a loose term. So no healing is your ACL deficient. And then non-anatomic healing is where it heals to the PCL or the lateral wall. And then you've got contiguous healing, where it goes from its anatomical footprint on the femur to the tibia. In our 585, we've got 500 at 12 weeks. So they've had a 12-week follow-up MRI. And we've got 85 that are still navigating the protocol. They're in a brace. So, but of the 500, we've got a 12-week MRI. We've got 95% healing, where the healing's either ACL, OAS, 1 or 2. So what that means, a 2 is healed, but it's either thinned or elongated. So it's like a suspension bridge running through the knee. It's a heel, but it's not the best heel because it's thinned or elongated. And then the nice, tight, but fully thick and taut heel is called a normal thickness taut, and that's an ACL OAS of 1. That usually becomes a 0 on the 12-month follow-up. So I know that's a bit confusing, but we've tried to pick patients that will do well. I've seen 1,200 patients in the last 5 years with ACLs, or looked at their MRIs, and I've sent 600 straight to surgeons. So I've just said, I think it's too profoundly hurt. Do you have private health insurance? And they say yes. I say, I think you should see a surgeon, because I don't think we're going to get the best outcome. So of the 585 that are braced, 20% had the perfect type of ACL type for this treatment. And as I've said, 95% had healing, and about 40% who had healing had the 1, which is normal thickness taut.
Yeah,
so it's a bit
fantastic.
confusing. There's a lot of healing.
No, that's
Depends.
great.
It really depends on where you are, where you land on the spectrum of injury, and you'll drop down into an according healing outcome. We think that you'll get a better healing outcome if you brace than if you do rehab alone. And so on that point, I think bracing 30 to 90, which has been definitely popularized in Australia and around the world, bracing 30 to 90 will give you a better healing outcome than rehab alone. It's my expert opinion. I know we don't have the science and the publications for that, but it's very apparent that if you can even brace 30 to 90 and try to stay at 90 most of the time in the first few weeks, especially if you've got the ability to work at home and be an office worker rather than the individual that has to go to work and stand up all day, they just will get a better healing outcome if they're sitting down all day with their knee at 90, even if they're braced 30 to 90. But we think cross-bracing protocol gives you an even better facilitation, because you're getting a better reduction and you're immobilizing in the critical first couple of weeks when the ACL needs to be reduced and the epiligament heal.
And that's probably a good time to bring up, Tom, what have been some of the criticisms of the cross bracing protocol, and who do you find is making those criticisms?
I can understand the fear of a new treatment, because it sort of disrupts the piece of what we've been taught, is that the ACL doesn't heal. So the biggest criticism is that the ACL is healing with scar tissue and it's a weak construct. And my argument to that would be every orthopedic injury undergoes healing and an initial period of scar tissue, which is young, immature, disorganized collagen. And we call that the healing zone. And we see it at 12 weeks on the MRI, and often it's exuberant and it's fusiform, and it looks like a callus. So if anyone's broken their clavicle, they get a big lump where it heals, and then that callus organizes itself into better organized bone. And that's what we see on the MRI of the healing ACL, is the rupture zone where it was ruptured. Once it unites, it becomes an exuberant healing zone at 12 weeks, which is made of quite disorganized type 3 immature collagen. And then all those cells in there, the fibrocytes, are extremely active. And then the patient doing this protocol who's might be a highly motivated young athlete, and she or he are going to the gym often. Every time they go there, they're stimulating that healing zone, and those cells realize that there's tension going through that construct, and they pump out. Our hypothesis is type 1 mature collagen that's organized. So the 12-month MRI looks sometimes anatomical, often, and it looks like a normal ACL, and you can't see the, for want of a better word, the scar at the 12-week mark. So we always tell people that they've got a young, fragile ACL that's healing at 12 weeks. And unfortunately, it takes, we think, 12 months to remodel the healing zone until we achieve peak tensile strength. The other interesting thing is some people biologically heal the healing zone better than others. And so we're a bit beholden to biology. So some of them may get a weak healing zone, others get a very strong healing zone. And they may have done the same rehab. They may have had the same diet. We haven't controlled for smoking and alcohol and things like that, but there's all types of determinants. And it's the same with ACL surgery. Some people get a really good graft and biologically integrate it into their knee and get a great blood supply. And others, and it's not the surgeon's fault, it's not the patient's fault or the physio, but biology just hasn't come to the party. And there might be an area of the graft that fails to integrate and isn't strong enough. And that's an area that might rupture for the patient when they go back to sport. So in both these treatments, biology can be encouraged by having a good diet and doing awesome rehab and having a great surgeon or adopting a non-surgical treatment. But at the end of the day, sometimes biology lets the patient down. So that's been an interesting journey through this research. I was in America last week at a meeting, at a conference called the Orthopedic Research Society, and I presented the poster of our research, and it was fascinating to listen to the Americans that they all have labs working, with really amazing young scientists who are working on tendinopathy and osteoarthritis, and they're working predominantly with rats, looking at right at the molecular and cellular level on how they can get a better outcome for the patient. But no one's looking at, there was one group in America looking at ligament healing. And I think it's fascinating to what's going on at a cellular level in that healing zone and how we could encourage it better with rehabilitation. What's the right amount of time to be immobilized in the cross bracing protocol? Is it 4 weeks at 90? Is it 3? Is it 2? And then when do we take the brace off and start stimulating the healing zone? So I think there's a lot of research that can be done either in Australia or internationally on this, always with the patient in mind, trying to get the best outcome. So I think it's a really exciting area of clinical work and also research. There's still a lot to learn, but we've got a lot of happy patients who are very happy they've tried this and done it or doing it. We haven't hurt anyone. So it's just another option for a patient.
Beautifully answered, mate. And so far, what has the return to sport rate been post cross bracing protocol after the 580 plus patients you have seen?
Okay, well, it's very important to note that only 300 are at 12 months to 10 years follow-up.
Exactly.
So we've only got that data on 300. It's about 80%. So we're presently working very hard at getting all the patient-reported outcome measures, the PROMs, getting them back into the clinic at 12 months for an MRI and a clinical review, so we can present that data in paper 3, which is an update on paper 1 based on the first 300. So we've got the results of the first 80. So paper 2 is the classification system, and 3 would be an update of the patient-reported outcome measures of how the patients are going. But, and this is, I'm sorry, I don't have the greatest evidence, but my clinical ability of being following these patients up is it's 80% of them are going back to sport. And the survivorship of the ACL, the healed ACL, is not 9% are crossing over to surgery of those 300. So, and that sort of challenges that whether that construct is a weak construct, that what they've healed. So that back to the criticisms, one of them is the ACLs, the healed ACLs is not as strong as an ACL reconstruction. So based on that, we don't think, and I would immediately shut down this treatment if the patients were rupturing their healed ACLs when they go back to sport. And there was my phone didn't stop ringing with, 200 of the 300 have ruptured. I'd shut this down ethically, but that's not happening. So that's critical.
And what's the comparison between the cross bracing protocol and, say, for instance, a patella graft versus a hamstring graft? I know I'm probably...
Well, no one's got that data.
Yeah.
So to do that properly, you'd need a randomized controlled trial with the 3 arms. You'd have to have a huge amount of money and power in the study. But if we know that.
Do you have a prediction?
Well, this is like, based on clinical experience and reading the literature. If you go to an elite surgeon, and we have many in Australia, these are young people going back to high demand ACL sports, who already have got risk factors for ACL injury. If they've had a non-contact ACL, they may have a family history. They may have hypermobility. They may be valgus, et cetera, et cetera. So in the expert surgeon's hands and seeing a great physio and a really motivated patient, there's still a failure rate of up to 15% when they go back to sport, and the patients know that, and they willingly go back to the sport they love, knowing that there's a failure rate. And that's unfortunately the nature of competitive sport that puts demands on the ACL. So we think our failure rate for when we get a really good heal, at the moment it's 9%, but it's early days. Like we've got 312. We get in a year's time, we'll have nearly 600 at 12 months. And then we'll have some really more powerful data. So it's a work in progress. We're just taking one patient at a time and offering them the treatment. We're working as hard as we can with the resources we have to do it scientifically, so that we can publish more papers to give the treatment more scientific gravitas, so that my colleagues, my doctors, physical therapists, allied health, and the patients have more confidence in the treatment, and we can really give them some meaningful data. So it's important to realise that the University of Melbourne have been very fortunate to get a grant from the NHMRC to conduct a randomised controlled trial that will start in the middle of this year, 2024. And the lead researcher is Stephanie Filbay, who's the first author of paper 1. So that would be comparing ACL reconstructive surgery versus cross bracing protocol, and hopefully having 90 patients in each arm. The patient will have to be randomized, so they'll have to say, I agree to end up in either arm. So, and it's only by doing research like that you can get level 1 evidence-based medicine that can give people more confidence that there's been a scientific method applied to this new treatment.
Fantastic. It's exciting. Any rough timelines on that? I'm sure that probably takes a fair while to get something like that going.
It'll before we can sit back and look at really meaningful data, and the clinicians and the patients can say, well, it's no longer level 4 or level 3 evidence, which is expert opinion or a case control study that's got a lot of scientific methodological limitations. Before we get to that, it might take 3 to 5 years. where we really have good evidence. And a lot of things in medicine start this way, with a new idea, and then, you know, a clinician or clinicians and that are working together. You have pioneering patients that are willing to try a new treatment, and then over time you get the science, and you can, and you can, and then it can potentially spread, become, perhaps, it might probably jumping the gun, but maybe it could get integrated into the treatment algorithm for ACL injury in all our clinics in Australia, New Zealand, around the world. When a young athlete comes in to the emergency department or the private clinic, or we're on the sideline with a ruptured ACL, and we go, well, guys, this is like a fracture. This patient's very important. We need to, especially if they're a child, we need to act on this. We've got to get an MRI. We need to do a thorough history examination, classify the MRI, and see if they're appropriate for either rehabilitation alone, perhaps bracing 30 to 90, or this one needs cross bracing, where we really need to get a better reduction. And this is the amount of time we're going to stay at 90. And then, or this patient needs a surgeon. So that'd be great if we could touch, more patients in that way, potentially, if we're right with this treatment. We think we are at the moment, because we're marching on. We're not stopping it, because we don't have enough concerns of any complications. We don't have, the results are very compelling. So we will march on one day at a time, until hopefully it's proven.
Geoff and I recently both went over to Japan, and we're thinking about going again this New Year's, January time. So maybe Geoff and I need to try and catch an edge, both of us, and then get a couple of other mates. There'll be 4 of us. We've all done our ACL, and then we can start the research that you just discussed. We can just flip a coin.
Well, I can tell you that in the 585, the number one cause of ACL injury is skiing. So by far and away. And Micah Van Harrigan, who's the research assistant here at the Stadium Clinic, she's patient 138 in the world. And she's a Dutch medical student, really helping the research team. She did her ACL in field hockey, and she's collecting all the data that we're talking about today to try and get the papers published. And so skiing's by far away out in front. And then it goes, number 2's soccer, so football, soccer. And then 3, touch football, OzTag. And then it goes netball, AFL, rugby league, rugby union, martial arts, particularly jiu-jitsu, surfing, motocross, putting your foot down on a motorbike. And then finally, we've dance floor injuries. We've had several of those, so maybe 15. And then just misadventures, falls, etc. But it's interesting, skiing's way out at the front. And on that note, what we've learned, perhaps we didn't cover it in the last time we talked, that really got beginning to understand that where you land on that spectrum of ACL injury depends on the energy exerted on your knee at that time of injury. And no more is that expressed better in the skiing ACLs we're seeing. So if you're down at the Snowy Mountains in Australia, or over in the Remarkables or the Southern Alps in New Zealand, or overseas skiing, and you're skiing at low velocity, you're a beginner, and you just fall over and twist your knee and feel a pop, versus the elite skier going 110 kilometers downhill, or jumping 5 meters in the air and landing, you're much more likely to have a non-surgical ACL if you're low to medium velocity. And this is going to be another paper that we're hoping to publish. So the velocity determines where you land on the spectrum of injury. So the high velocity, jumping in the air, large gap distance, displacement of ACL tissue out of the notch. Whereas the low energy, low velocity, it's within the synovial envelope, the injury, maybe a much lesser gap distance, no displacement. So that's quite fascinating, and can often diagnose where they are on the spectrum over the phone. You say, or how fast were you running? Were you at maximal speed? Yes, I was going really fast, and I changed direction. No one was around me. I pivoted. My knee gave way. It was incredibly painful. I was carried from the field of play. Within an hour, my knee was very swollen. I can't wait there. Immediately, I'm thinking, this is a really good athlete running at maximal velocity. They've had a non-contact ACL. They've probably got a large bone bruise because their knees got given away at a maximal velocity. That's causing a lot of pain, also causing bleeding. They've probably got a displaced ACL, synovial envelopes breached, ACLs sitting under the lateral femoral condyle or anterior, pumping out blood into the knee. That's why it swelled so quickly. They may have other injuries, meniscal tears, bone bruises, subchondral fractures, posterolateral corner injury. We haven't touched on that, but there are other things to look for clinically and on MRI that exclude people from the cross bracing protocol, and equal, they need a surgeon. So yeah, talking to the patient about the mechanism is critical. How much energy was going through your knee at the time of injury will determine whether you might be a candidate to get a really good healing outcome with a non-surgical approach. So that's been another learning experience in the last 12 months.
Geoff, when you were overseas, were you concerned? Obviously, you were snowboarding, and I snowboarded and I skied. But were you concerned about doing your ACL? Because I went over there based off the fact that we've had this discussion, Tom, so many times in the last 12 months, and I've never in my life had it in the back of my head about doing my ACL when I was skiing. But when I was really sending it in Japan, I'd get to the end of the run and I'd kind of be thankful that I hadn't done it in a way.
Yeah. I mean, I snowboard, so I wasn't too worried, to be honest. But I mean, I saw in the little hostel that I was staying at, there was a lady did her ACL while we were there. And she had actually got really unhelpful advice, being braced with her knee in straight. And I advised her to go and see the other physio in town, who I knew had consulted with Tom. And so fortunately, she got some good advice around that. But it does. It really highlights, especially skiing seems to be a really, really dangerous one for ACLs.
This podcast nearly came at somewhat of a shocking time. So yesterday I was playing tennis and the courts were a little bit wet. And I went out onto my backhand wing and I tried to change direction after I'd hit my backhand, and my foot landed on a bit of a wet area and it slipped, and I had a valgus position, and the first, like, I was fine and my knee's all good and my hip's a little bit tall, but it was that classic kind of mechanism, and it would have looked kind of like I'd done my ACL and I just went down. And imagine if we were doing that today and I'm sitting here after seeing Tom this morning or something.
We've on that note, we've only had perhaps 3 tennis players.
Yeah, right.
Who I've seen out of the 1,200 ACLs I've seen. So it's not a very common mechanism, tennis, to do your ACL. Like you said, it's usually uncoordinated sidestep where they get a valgus moment through their knee. Yeah, so skiing, I absolutely love skiing, but I ski myself, and I ski a lot more conservatively now than I ever did when I was 16, 17, etc. But you could argue the human being wasn't meant to put a big ski boot on with a ski. Like, we're not, as human beings, or we're not meant to have a ski on our leg and ski down the slopes. And I love skiing, and I think people should continue doing it. But it's a really, really good way. If you do catch an edge, you get that torque, twisting moment through your knee that can exceed the tensile strength of your ACL and other things in your other structures in your knee. So, but I'll keep skiing, and I encourage people, but they need to be really fit. I would argue you should see a physiotherapist or an exercise physiologist, months before you go on that ski vacation, so you you mitigate the risk of an ACL. You get nice and strong, and you'll enjoy the holiday more. And then simple things like not going out on days where it's poor visibility, poor snow conditions. If you're tired, it's watching your speed, how fast you're going, etc. So this holiday that's meant to be a great reward for you and your family doesn't turn into a disaster where you get hurt.
I would say one thing about that. I feel like people leave it way too late. I see this so many times. They come in with 3 weeks to go until their skiing trip, and they're like, "Get me strong." And I'm like,
Yeah.
you should have done it at least 3 months before your trip. If you've pre-planned it, ideally that would be good, and in the ideal scenario, you'd train for life and you continue to do that forever. So you are always ski ready.
Yeah. Yeah. So what do you think the minimum time they should present to your clinics?
3 months. 3 months.
Okay.
Yeah, minimum. Would be ideal, but we still get some people, that,
Yeah.
and you don't know what you don't know. They don't know that they need that amount of time. So things like this podcast, etc., can educate people on the fact that you do need more time, rather than 2 or 3 weeks before it to get strong and fit for skiing or snowboarding. With the snowboarding and skiing in mind, Tom, how many snowboarders have you seen? Because obviously you
Very
haven't seen
few.
one. Oh,
Well,
right,
we've seen several.
right.
10, I would estimate. Micah, research assistant, will have more knowledge, but I would estimate there's been 10, whereas there'd be 250 skiers in the
Yep.
585. So the snowboarders get more upper limb injuries from falling, dislocated shoulders, wrist fractures. You can get an ACL from a snowboard. It usually happens to the front leg as the board rotates, but I just don't see them. They might be going to the surgeons but they're just not seeing me. So I would estimate, 20-1 skiers to snowboarders for ACL.
It influenced my decision this year. I snowboarded for 2 days. Sorry, yeah, 2 days, and then I skied for 3. And I, considering maybe if we go Geoff, that maybe I'll stick on the snowboard.
Good man. We all know snowboarding's better, right, Andy? Tom, little change of pace, mate. Do you have any data yet on osteoarthritis rates, or is that something that you will be collecting?
Answer is no, because we don't have enough long-term data. So we've got one patient at 10 years, patient number 1. And then remember, in the first 5 years, from 2014 to 2019, we only had 5 patients who were family, friends, colleagues, children of friends. So over the last 5 years, that's not enough long-term data for OA. No one's got OA yet. My feeling is and we've got a really interesting cohort in the 585. We've got approximately 75 patients who have had a reconstruction of one knee and then ruptured their contralateral knee or their other knee ACL, and then saw me and chose the cross bracing protocol. So they're going to be a really interesting group to follow over the next 15 to 20 years of what happens to their ACL reconstructed knee and their healed ACL. I mean, it's just too early to know. Every patient knows that we're really interested in them, and they're interested and very active, wanting to be in the research. Nearly 95% of them consent to, I want to be followed up. Please contact me in 10 years by email or mobile phone. I'm very willing to help. So it'll be really interesting in the next 15 to 20 years to follow them up and see whether they do get OA. My expert opinion, once again, level 4 evidence, is that for the ones who get the really good heels, so the normal thickness and taunt, so basically it's like a time machine. And once again, if they biologically integrated the healing zone and it looks like a beautiful ACL, they examine well, and they don't have other serious concomitant injuries to their knee. So they didn't have a significant meniscal tear. They haven't had a large area of their articular cartilage injured in the in the moment of injury, I think they're going to be fine. I don't think they'll have an elevated risk of OA at all. So that's my opinion. Um, they say to me 2 or 3 years after they've done the treatment, my knee feels great. It feels normal. And so, yeah, the answer is we don't know. We don't have the data, but level expert opinion for those who get fabulous healing outcomes with no other significant injuries, I think the answer is no elevated risk.
Yeah, great. Thanks for sharing that, Tom. Is there any other research that has sort of branched out from this? Like something that's popped into my head is I know you've mentioned that there might be some signs of healing of meniscal tears, like acute meniscal tears. Is there anything else that's branched out of this, or there could be in the pipeline if you're not busy enough?
Well, I mean, might be on shaky ground in terms of, science, because we haven't published on that. That we did mention in paper 1 how many had meniscal tears or meniscal damage that was considered stable, and it was a large number. It was approximately 50% of the first 80 patients had signs of a meniscal injury, either to the medial or the lateral. So when the femur subluxes on the tibia at that moment of injury, it's sort of like a surfboard when you hit the fiberglass, the rails with your knee, or the surfer, that you may ding the fiberglass. You can ding or touch up the articular cartilage or the menisci. So when we evaluate the MRI, my eyes go first to the ACL and classify where it's injured and look for those criteria: gap distance displacement, any interrogation of the femoral footprint, any injury down at the tibial footprint. Is it involuting or dying because they're presented late? And then as soon as I've classified the ACL, then we look at the rest of the knee. So articular cartilage, menisci, posterolateral corner, medial ligament, lateral ligament, etc., to make sure that this patient may need a surgeon. They've got a bucket handle meniscal tear, they've got an unstable meniscal tear. But the ones that we deem stable meniscal tears might be vertical tears in the periphery of the medial or lateral meniscus. So the meniscus has got a split in it vertically. We tell the patients, and there's a lot of them, it would be 40 to 50% of the patients we brace have some edema or indeed a vertical tear. Some of them have a ramp lesion of the medial meniscus. So there's actual fragment displaced posteriorly on the medial meniscus. We say to them, look, you may need an arthroscopy for that meniscal damage. But the intention of this treatment is to try and heal your ACL and get a better healing outcome. And they say, look, that's fine. I consent that I might need an arthroscopy. But the crossing over to arthroscopy for meniscal tears has been extremely low. We've only had 5 patients in the whole cohort cross over for a meniscal tear, when 40 to 50% of them have meniscal tears. So this is a whole nother paper that I would urge another researcher to do, perhaps. But the fact that you take the knee into flexion and go non-weight bearing may potentially help a lot of meniscal tears heal. Now that's a big statement, and I don't want to upset any other doctors, but that's our experience in this journey over the last 5 years, that we think that the motion of going immobilizing at 90 and being non-weight bearing gives the meniscus a chance to heal and stick. And we've seen ramp lesions or retropulsed fragments of the medial meniscus reduce back into the knee and then heal. We've had several examples of that, and we haven't got the time to publish on that, but it's definitely been a finding. So it's interesting. On the subject of who needs a surgeon, like if the patient has a significant posterolateral corner injury, that's a contraindication to be non-surgical and put the patient in a brace, because they need a surgeon to address that significant disruption. For the clinicians out there and the patients, it's usually a high energy injury. like the patient's running at speed or jumping and landing, and they get a significant hyperextension injury that pulls the whole postlateral corner off. The other ones to look out for are bucket hand or meniscal tears, where a piece of meniscus is sitting in the notch, and that's certainly needs a surgeon. So if they've got a significant osteochondral injury and a loose body in the knee, so always these are the more high energy ACLs, I feel, and they're already going to probably need a surgeon anyway because the ACL so badly hurt. But it's very important that these patients are thoroughly assessed, but clinically, and also the MRI is classified accurately. And on that note, you really do need a doctor doing this assessment with an expert radiologist, and they're talking and classifying. And then as soon as the patient's consented to adopt a non-surgical treatment, then you engage an expert physio that loves ACL, like the two of you that are very good at it. And that's your team of three: the doctor, clinician, radiologist, expert physio, and you're away. You do need a doctor to do this shared decision process because a lot of these patients are on medications, they've got medical conditions, and unfortunately the physiotherapy training, with the greatest respect, doesn't give you enough knowledge of those medications and the interactions that may happen with being non-weight bearing or using the anticoagulant Xarelto, knowing the nuances of who needs surgery and who doesn't. So ideally, the patient should see a clinician who really understands it, a doctor. That doctor could be a GP, a sports doctor, a sport and exercise medicine physician like me. It could be an orthopedic surgeon who really is an early adopter of this novel treatment and thinks, I'd like to manage patients in this way. And there are several orthopedic surgeons in Australia and New Zealand who are early adopters of the cross bracing protocol and have rung me and said, I really like this. It's a great option. And if my daughter did her ACL and she was a good candidate, I'd try this first. And if it didn't work, we can always do surgery. So for patients out there listening, please don't take yourself to 90 degrees because you're worried that you're missing the boat. We have to do this safely. You have to see a doctor who understands this treatment. And you have to do this treatment very safely, because if you go to 90, you could get a DVT and you're not protected with an anticoagulant. You could get a DVT, that DVT could go to your lungs and you could die. And I'm not being, we have to talk in these terms of the worst case scenario. So please please get medical opinion and do everything we're talking about, and engage that team of three to get the best possible knowledge. And then like we've talked about off air, guys, it's the patient who decides on what treatment they'd like to do. We're just here to give them all the knowledge, and then they assimilate it in their mind and they go with their brain and their heart of what they'd like to do. Excuse me. Their resources, do they have enough private health insurance for surgery or not, et cetera, et cetera. There is a website called Heal ACL that it's in its infancy, but we're building it very carefully to try and be that one place where the patient can go to learn more about all their options. So that's called Heal ACL. It's going to hopefully it will get more and more information on it to give the patients more knowledge.
We've touched on it before in other podcasts about the utility of the cross bracing protocol in third world countries. With that in mind, has there been any movements in terms of an overseas third world country research satellite clinic? Where are we at there? Because we've previously mentioned Fiji and other places that could benefit from the cross bracing protocol.
That's a great topic, and that topic has really motivated me the last 5 years, because it's been a hard 5 years, trying to pioneer this treatment and as I said, one patient at a time. but what's motivated me the most is the patients that have, you know, been courageous enough to take on a new treatment. But the patients who will benefit most to this are the patients that don't have the option of surgery. And there's a lot of places on the planet with no MRI, let alone access to an excellent orthopedic surgeon. So if you can do it safely, with what we talked about today, you could empirically brace all the young athletes that do their ACL in developing countries around the world, or even in Australia, in communities where they don't have health insurance, or they don't have a lot of money or access to surgery. So that's really exciting that we can help, you know, perhaps millions of young athletic people who rupture their ACL with this new treatment and empirically brace. They will need to be covered with an anticoagulant, and they will need a clinic nurse perhaps to coordinate that, and an expert physio, which most developing countries have, and Fiji definitely has that. And the other group that really, as we've touched on today, are the children, where surgery is very challenging to reconstruct a child's ACL because they're open growth plates, and the younger the child, the more challenging. And they've got such their long life ahead of them to suffer this burden of perhaps instability. So the children really motivate me to develop this treatment and try to get it out there, and stabilize kids' knees, perhaps without for the ones that classify that are appropriate, with this new treatment. But it isn't happening in the developing world. I think once we get more papers and more knowledge and awareness, people will start doing it, and I think it'll be written into perhaps the World Health Organization. You need a lot of scientific publications and gravitas before the World Health Organization writes and decrees that this is a new treatment that must be enacted around the world. And that might be 3 to 5 years away. One of the surgeons from Queensland rang me, and he visits Fiji. I think we may have touched on it in a previous podcast. And he said, "This is great. I love it." That's Dr. Michael McAuliffe. So he benevolently goes over to Fiji and operates on these ACL deficient young men and women. And he said, "Look, this is fantastic. Like, we might be able to save some of these ACLs with this treatment." So rather than have be ACL deficient or have a reconstruction,
the cost alone is a huge reason as well.
Yeah, so it is a very expensive process for a developing nation to offer this elective operation. There's obviously other health matters that trump the ACL, with medical, with their nutrition and infectious disease, etc. So ACL would be very low on the list of priorities. But if we can say this is a very cost-effective and cheap way to look after these young people, then I think they would embrace it. All you need is some anticoagulants, a brace, and a physical therapist and a clinic nurse. And we can write, we're in the process of writing a manual to teach this, and for clinicians and physios to learn the treatment and to enact it effectively and safely, so that you get an effective outcome, and also you do it safely and no one gets hurt. But yeah,
Tom, I'm very mindful of your time, mate, and I just wanted to thank you so much for your generosity in pioneering this program. I've had a few snapshots into the amount of time that you spend with people, and it's very selfless and amazing to see, mate. So thank you so much for sharing your time today to come onto the podcast with Andrew and I. Did you have any final thoughts or advice that you wanted to share with people?
I think just know that we're working as hard as we can to get the scientific publications. We're collaborating with many experts at the University of Melbourne, with the University of Sydney, with surgeons here in Sydney at the Sydney Orthopaedic Research Institute, There's 5 surgeons there and their team with radiology companies, PRP in Sydney, Castlereagh also in Sydney, and we're collaborating with clinicians and colleagues in New Zealand, sport and exercise medicine physicians, orthopedic surgeons and radiologists in New Zealand, and physiotherapists in New Zealand. So there's a lot of collaboration, and I thank all of those people dearly that that believe in this new treatment. I thank the patients and their families who have, and you know them because both of you have managed patients from beginning to end through this treatment. But know that we're working as hard as we can to get the science. We're trying to do it very carefully. We're trying to do it ethically with medical, expertise. A new treatment does require a lot of time. Like you can't cut corners, and the patient has to be fully informed about all their options before they choose the option for them. So until we do get the science, I'll keep working as hard as I can. And I thank everyone else who's like the two of you, who have been great advocates, early adopters. And hopefully we can get that science and more people can choose this treatment. It becomes more available. So yeah, that'd be my message, is watch this space. If we start encountering anything that's worrying, then we will address that. But certainly I don't think there's enough at the moment to stop this treatment and shut it down, where if anything, it's more compelling. So yeah, thank everyone for their help. The front desk, I've mentioned it before, but our reception, I couldn't do it without the reception team and my staff here at the Stadium Clinic. They've been magnificent. It's a team effort. So we'll all work together, we'll get the science, and then we'll just keep reevaluating, and hopefully it'll grow.
I can attest to that the Stadium Clinic's reception is phenomenal. Last year, when one of my young footballers went down right in front of me, the process of calling up and getting an appointment within 16 hours is just unbelievable. So yes, I agree.
That they know that it's a time-sensitive injury.
Yeah,
like they're well aware. So I look forward to the day where we don't see the late presenter. We don't see the patient coming in like the 19-year-old girl this week who was invalided on day 19 that we talked about earlier. And we can get the message that right to the emergency department, to the cold face, and we can enact the treatment within 7 days. So that's exciting. But yeah, thank you guys for your time. It's always great catching up, and we can do it again down the line if you like, for sure.
Yeah, I think we definitely need to do a 3.4.5.0 at some point. But thank you for all that you're doing with this research, Tom. Thank you for your time. And
Thanks,
Merv would be unbelievably proud of all the hard work and effort you're putting in. So congratulations.
Well, appreciate it very much. Thanks, guys.
Absolute pleasure, mate. We'll do it again soon. Thanks again to Tom and Geoff. And as usual, stay strong.